Welcome everyone. This is our second foot and ankle webinar of the year. But the exciting thing is tonight's webinar, we are actually kicking off a foot and ankle webinar series. Currently, we are actively gathering data on autologous biologic treatments specific to the foot and ankle, which we will present in the upcoming series throughout the series as we gain more and more data with that. If you're interested in participating in the data collection or studies with APEX Biologix, please reach out to me. My contact information will be listed at the end of this webinar. The exciting thing is tonight we are fortunate to have 3 esteemed doctors providing valuable information on advancing foot and ankle healing and recovery by way of PRP, protein concentrate, and talking cash pay for regenerative medicine. Unfortunately, we will not be able to hear from Dr. Chris Heyer tonight due to an unforeseen personal obligation. However, we do have Dr. Bert Mandelbaum, who will be pre-recorded as he is currently with the U.S. men's soccer team playing against Panama right now in Copa America. So just to do a quick introduction on Dr. Bert Mandelbaum, he is our leading orthopedic expert, graduated from Washington University Medical School and completed his residency at the Johns Hopkins Hospital. He now works at the Cedars-Sinai Kerlan-Jobe Institute, affiliated with UCLA. Renowned for his research and contributions to sports medicine, he has served as a team physician for UCLA Athletics and LA Galaxy. He has also played vital roles in FIFA World Cups and the Olympic Games, earning accolades such as an honorary doctorate from the State University of New York in 2009. And then moving on to Dr. James Cottom, who is here with us tonight. He is a highly skilled orthopedic foot and ankle surgeon based in Sarasota, Florida, specialized in trauma and reconstructive surgery of the lower limb. He directs the 12-month foot and ankle fellowship at the Florida Orthopedic Foot and Ankle Center and has trained numerous fellows. He holds degrees from Scholl College and Wayne State University, and he completed a prestigious fellowship in Columbus, Ohio. Dr. Cottom is a prolific author with over 60 peer-reviewed publications and is recognized for his research at both state and national levels. He is renowned for his expertise lecturing internationally and teaching advanced surgical techniques. And Dr. Ariana DeMers, who is a board-certified, fellowship-trained orthopedic sports medicine surgeon. She is the past president of the Interventional Orthobiologics Foundation and is a sought-after educator and trainer in orthobiologics and ultrasound. She has successfully transitioned her rural practice away from commercial insurance to focus on holistic orthopedics. So due to the men's national soccer team playing in Copa America tonight, we did have Dr. Mandelbaum's session pre-recorded. And as I previously stated, Dr. Mandelbaum is an orthopedic surgeon and will discuss the history and progression of injection treatments in medicine, focusing on knee treatments often compared to HA injections. Where the most data is currently available, we feel it's important to review the science and history of autologous biologics and ongoing research before we dive into foot and ankle applications.
Hi, Dr. Bert Mandelbaum. I'm sorry I can't be there at that great meeting, but please enjoy. My topic is about orthobiologics, the basic science and rationale for clinical use that we'd like to see all of you think about and engage in your clinical practice. The future of orthobiologics is really focused on lots of growth. We use the innovation diffusion curve as a way to look at the future in such a way that there's a progression that starts with early innovators, adopters, an early majority, a late majority, and then comes the laggards. And that typically is the progression that we see going forward. One issue and one challenge is the FDA that gives us mostly autologous regenerative therapies. We're regulated against using stem cell products, fat-derived cells, umbilical cord exosomes, amniotic fluid, Wharton jelly, all of which can be used under an IND situation. So with that, we have to think about where we're going forward. And we learn about adjuvants therapies, which are substances and interventions that can work together, and most importantly, that can prove the efficacy, just like we see, for example, in oncology, where an adjuvant therapy group can be improved from up with no adjuvant therapy at 39 to 74.2%. We have to think of the same way conceptually in terms of adjuvant therapies. But we also know that all of regenerative medicine is about adjuvant therapy. It takes cells, it takes scaffolds, and it takes growth factors and or cytokines to really make it happen. We have a whole family of things that you'll hear about today, all from corticosteroids to WNT pathway inhibitors and everything in between. So the real question is, what are the adjuvant combinations that's best? Let's go through some of the basics. Simple thing, glucosamine. Mike Shikati has told us in systematic review that it may protect the joint cartilage and delay OA. Even melatonin has a role, as we've seen, by decreasing levels of interleukin-1b in a very statistical manner in basic science studies. How about high hyaluronic acid? We know it decreases the inflammatory response, it protects cartilage degeneration, but they're all not alike. As we've learned, high molecular weight, HA, has a significant effect when you look at all the studies in this network meta-analysis, as it certainly did meet the criteria of the minimally clinically important improvement with only high molecular weight and not low. As we move forward on into PRP, 5 things we need to know about the ABCs of PRP. You have to know, is it buffy coat or plasma? There's the buffy coat right there. So you can see here, taking that PRP right from that level. What's the platelet concentration? What's the leukocyte concentration, rich or poor? How about activated calcium chloride and thrombin? And how about the dosing, how often you give that? And all of which becomes really important. Lots of studies in terms of the mechanism of action, in terms of what it inhibits, how it affects, which genes it turns on and off, but there's no question it has a definite role on the mechanism of action. But in the end of the day, what we see here is that the MSCs and PRP are an auger, and when PRP is around, guess where these MSCs go? They swim right to the PRP. When they get there, they proliferate, all of which having a positive effect. All the growth factors in those granules are released, have a positive effect on cartilage, regeneration of the synovium, meniscus, and chondrocytes as the organ going forward. So those are the mechanisms that we know. And again, constantly we're trying to flip catabolism to anabolism, as it's an anabolic and an anti-inflammatory, by stimulating proliferation, as you've seen, potentiating SOX9 and elevating COX-2A1 and ACAN expression. We also know there's many different studies in terms of the efficacy in knee OA. We won't really focus on that, but let's focus on some of the high points. For example, we learned that 10 billion platelets in this study is crucial for long-term sustained chondroprotective effect. And we learned from our study that we did as part of our study, our ROCK and BARB study, was we found a direct relationship between responders and the absolute platelet count, which is also seen in these studies, where you see a variety of high or low platelets in comparison. As you go out to 3, 6, and 12 months, the green is showing more platelets, better response in all of these studies. It seems to be the more, the better overall. How about in terms of activation? You can see the platelets at rest in this photograph, and over here they're activated, they're moving, they're improving, they're coagulating, they're releasing the granules, and it seems to have a direct relationship, activation, with better efficacy. Adam Ants has looked at exercise, and he describes 20 minutes of vigorous bicycle exercise significantly increased concentration of platelets by over 20%. So exercise matters going forward. And now we're tweaking in other ways. How about when we put an adjuvant combination of HA and PRP, what we call PRP 3.0? It induces a release of TGF-beta and PGF from the PRP, creating a better response. And there are several studies that show, in this systematic review, HA plus PRP is better than PRP alone. And in this, coming from Brian Cole from Chicago, PRP and HA is better than HA alone. And when we look at this and we look at bone marrow aspirate concentration, especially when we compare it to PRP, we find in this study, again at AMANCE, in this 2-year prospective randomized trial, was that BMAC was not superior to PRP. And in addition, when we compare this systematic review, we find that BMAC is effective, but demonstrated no clinical superiority to the other therapies. And then when we compare BMAC with stromal vascular fraction injections, we again find there is equivalency here. And lastly, in the study by Alberto Gobi from Milan, he looked at autologous microfragmented adipose tissue in comparison to PRP, and once again showed there was no great advantage. And lastly, in this study from Porto, João Esparguera Mendes finds that when he puts PRP with culture expanded MSCs and adds them together, that seems to be the significant optimal approach. So it appears as if it's these interactions between a PRP, MSCs, HA that optimizes in an adjuvant way. And we bring another player in our family called alpha-2 microglobulin.
Turning it into
And
a
it
drop.
works like a Venus flytrap, just like that. Proteases are exposed to it, and what happens is it decreases the level of MMPs and TNF, neutralizes the interleukins, and increases the expression of cartilage protective genes, COL1, type 2, SMAD4, and aggrecan, all of which are affected. Also, the group from NYU has shown that the effectiveness of A2M injections for the knee are similar to PRP and corticosteroids. At this moment, we're looking at work in progress, combining high molecular HA, PRP, and A2M all together. And again, what we've learned in our approaches here is that precision medicine, the devil is in the details. All of nature, just like you see, this orca whale hunting is very specific. The specificity of platelet numbers, use of activators, a triad is critical, but at the end of the day, the combination adjuvant therapies may be synergistic to optimize results in all of our patients. We need to continue this work in progress, and it's very exciting, and we look forward to the next steps. So thank you very much. Enjoy the rest of the webinar, and have a great evening.
So we'd like to take this time to thank Dr. Mandelbaum for taking the time to pre-record this and share his insights. Currently, for any of you that may be interested, they are tied with Panama 1-1 in the second half. So we're hoping that they can pull that off and come through with the win. So again, just to reemphasize what Dr. Mandelbaum was talking about, and the importance of dosage and moving forward and kind of setting up the science behind PRP. We would now like to transition more into the foot and ankle aspect of it. And before I turn the time over to Dr. Cottom, I should have acknowledged this in the beginning, but Dr. DeMers is actually joining us from Turkey tonight. So bright and early in the morning for her, and the lights don't want to come on. So she's got the floating head going around, but we are so very grateful for her to be here and for her waking up in the middle of the night to do this. So now, Dr. Cottom, we'd love to turn the time over to you and dig a little more into the foot and ankle usage of PRP.
All right. Can you see my screen okay?
Yes, sir.
Good deal. So, all right. Well, thanks for the invite tonight. It's a real pleasure to be here. So I'm just going to talk about my experience with PRP over the years in both the clinic and then in the operating room as well, specifically with the in the foot and ankle arena, if you will. So here you've got two X-rays, two patients, very similar end stage arthritis. In our practice here down in Florida, we've got minimal options for these patients when they get to this point. But I can tell you, on these two patients, both were treated in the office. One patient, believe it or not, underwent an ankle replacement and wound up doing real well with that. The patient on the left, PRP injection, and this was 4 years later. The same patient there, still with no ankle replacement in there. So we were able to go ahead and buy some time, some longevity for that patient, and that patient has still not been implanted. So again, there's a lot we can do with this in the right setting. And so that's something that we want to look at. So PRP in the office, I've been interested in this since back before 2010. What I've noticed over the years is just better outcomes with my patients. And in the community I'm in Sarasota, Florida. If I don't do this, somebody else will in the area. And that was one thing that I always wanted to kind of jump on this once I start reading about the science and the data behind it. The nice thing with APEX, and we'll go through, is we can really regulate the injection, what's in that. We can regulate how many white blood cells we have in there, or how many white blood cells we don't have in our leukocytes. In the past, there's been a lot of mixed studies, but I think as time has evolved and we've been looking at the studies on PRP, there's been better protocols designed, better data collection, in all, better research, which have led to better studies. And so again, as Dr. Mandelbaum just kind of explained to us, there's a lot of science behind this, and the data is actually looking pretty good for this. So in my office, or what do we offer patients? Anything from any of the 33 joints in the foot can be treated with this. Achilles, tendonitis, partial tears, any soft tissue, whether it's a tendon or ligament issue, can be treated as well. I don't do this much in my practice, but I think there's a role in some certain situations in some wound care with this as well. And then there are there's some data out there in regards to treating neuritis and nerve type symptoms as well with this. But I think it's really important to figure out who are we going to offer this to. So, and my first question for all my patients when they come is what are your expectations? What do you want to get out of this treatment? And I think that's very important for everybody to be on the same page from the get-go. And that's something that needs to be established right at the beginning. You got to be cognizant of your smokers. What about those with PVD, poor nutrition? I generally don't want to inject anybody if they've had a steroid injection to that particular area or joint 4 weeks prior. And you also need to be careful about when do we allow these patients to return back to their either activities of daily living or sports. If they're a high level athlete, that has to all be timed appropriately to get the best possible outcome. Obviously, your patients need to be able to afford this because this is not covered by insurance. In my area where I'm at, a lot of my patients have read up about it, and I get a lot of people coming in actually asking about these type of treatments. They've done a little bit of homework. And again, here I've got an elderly population. A lot of my patients, honestly, would be better off without surgery. So if we can get them to a tolerable point in regards to their pain level and function, I think we're doing them a good service with that. And again, those who won't comply with our post-injection protocol as well. I think too, labs are something that's important to get. Usually you'll get a CBC. You can always look at testosterone, vitamin D, helps the immune system and helps calcium absorption as well. Absolute contraindications, patients with platelets dysfunction, critical thrombocytopenia, relative contraindications. And I think it's one reason too, if you're going to do this, just get some labs and look at the hemoglobin levels as well as platelet counts, because those may also tell you something about if this is a particular option for this patient. So I've tried a lot of systems in the past, and what caught my eye with APEX? Well, first of all, I've been in practice 17 years out of my orthopedic fellowship, and I consider it my responsibility to pay attention to technology and what's new, what's coming out that's new out there that could eventually or ultimately help my patients. I like APEX because the data I've seen has been solid. I think they built a better mousetrap in regards to the PRP system. And overall, to me, it makes sense. And there's some, I don't know if we have images of this tonight, but they have something called the bench top press. And there's a little light that you can light up in the back of this. And you can mix some of this in front of the patients. And the patients I've done this in front of just think it's really cool. It's cool to see. And it's just kind of the whole part of the experience for them as well. So APEX has industry-leading increases in growth factors, and as we brought up, alpha-2 macroglobulins, cytokines as well, and IRAP. They have a protein concentrator, and I'll show you some slides on that, but you can really remove quite a bit of water, about 75% of the actual volume with this protein concentrator, and that will increase the retention of the proteins that ultimately can be injected and used. We're seeing concentrations up to 9-time baseline with a specific instrumentation and an average platelet count of over 1 million. There's over 7.5 billion platelets in a single dose, according to the white papers. But this is where it can get confusing because there's different companies out there and everybody's promoting their PRP, but the kits, just like anything, are not all the same. They've got differences in concentration, purity, the platelet dose. So really what you want to do, you want to look for higher concentrated systems, higher purity, over 90% pure platelets. And again, proper dosing. Again, usually you want to get 4 to 6 times baseline in the platelets in a syringe. And again, obviously we can get more with APEX, which again, that's what attracted me to this. With this too, as we'll go through, you're able to concentrate your injection with either a low leukocyte or a leukocyte rich, if you will, draw. So the leukocyte pore, if you will have 6-time baseline platelets. Again, you can remove up to 90% of the red blood cells, and the leukocytes are reduced about 3 times from their baseline. And if you want to enrich them too, you can increase the platelets, the leukocytes about 5.3 platelets 5.3 times, and the leukocytes are increased again above 5 times baseline with this. So it allows you to dial in if you're treating a joint versus a soft tissue issue. That's how I kind of utilize these different formulations. So what really got me here was the protein concentrator, and that's what this is. This is extremely easy to use. And what this is going to do, it's going to remove water in your platelet poor plasma. And it's really going to concentrate those key cytokines, as we saw earlier, the A2M and IRAP. And in my eyes, this is really best in class. And you're obtaining a super concentration, if you will, to utilize in your patient. So with this concentrator, we're able to collect about 3 to 8 milliliters of concentrated proteins. And then what we're able to do, you can see here the picture on the right, where they're transferring the protein concentrate, and that kind of red down there is already the PRP we've already obtained from this particular patient. And once it's all said and done, you get about 4 milliliters or 4 cc's out of that protein, that filter, that concentrator, when it's all said and done. And that's after removing all the water and filtering that down to basically as low as it'll go. We just saw a similar slide on this, but again, this really caught my eye with this. The A2M is a protease inhibitor. So when we're treating osteoarthritis, I equate these guys to like Pac-Men. They're basically injected into the joint, and they inactivate chemicals that help break down cartilage, and they also act as a powerful anti-inflammatory. The issue with these, though, is these are high molecular weight macroglobulins, so they can't really migrate through the joint capsular synovium. So they need to be placed in there, injected in there. And with this, we can obtain a supraphysiologic dose. The IRAP inhibits interleukin-1 from binding to receptors, and basically can help slow progression of arthritis. And so, again, this is something that caught my eye when I first started looking into this system. And there's a lot of studies coming out. This is a recent one I just saw back in, came out last month in the Orthopedic Journal of Sports Medicine. They looked at 41 patients, looking at ultrasound guidance, PRP injections versus needling for greater trochanteric pain syndrome. And the PRP in this was noted to be statistically significant better. However, what they also concluded a platelets above 3.5 billion and likely higher is necessary. And so that's what a lot of these studies are starting to look at, or starting to conclude if you look at them. Just like Dr. Mandelbaum was commenting, more I think is better with this, and that's what we're starting to see with things. And so in my office, this is a typical patient that we would see, and this would be somebody that we would consider offering PRP treatment too, as well in the office under ultrasound guidance. So this is a 57-year-old female, 3 years of chronic plantar fasciitis, treated at outside institutions. She came in to see us, and if I see a patient with long-standing plantar fasciitis, I'll often think about getting an MRI just to make sure nothing else is going on. And most of the time, we'll find interstitial tears in these long-standing situations. And so we'll treat them with first offloading, whether it be a tall cam walker boot or some sort of a plantar fascia offloading brace, and a PRP injection under ultrasound guidance. In this particular patient, she was doing about 75% better at 6 weeks and 95% better at 12 weeks. And I think it's important too to protect these long term. So we, after the 12-week mark, we actually got her a custom orthotic as well. This is just prepping for a posterior tibial tendon injection, again, under ultrasound guidance in the office with this. And this is one where we would go ahead and add some leukocytes in this to go ahead and just recognize and observe our natural phases of healing as well. So that's one thing with ultrasound. If you haven't started doing these in your practice or started thinking about this, ultrasound is going to be something that you're going to want to be able to get your hands on and understand. So they've offer courses all the time, but this is something that would be very, very beneficial and important. Ultrasound studies have increased over from 2000 to 2019 by over 700%. We've got small portable machines that you can get relatively inexpensive and still give you high quality images. And again, with some of these second and third generation machines, additional procedures can even be done in the office, whether they're tenotomies or debridements. There's mention of nerve entrapment release as well as A1 pulley release in the hand. And so it's good to get your hands on these and get comfortable with them. So this is a long axis view of an Achilles tendon here. You can see the top picture, just some of these disorganized fibers running through here. You can see on the lower right-hand picture as I'm introducing a needle, you can see this region of hypoechoic region that we want to go ahead and infiltrate with PRP. And we can go ahead and do this under live ultrasound guidance. This is same patient 24 weeks after a PRP injection. So on the left is before. On the right here, you can see how these fibers are all linear. They're lining up nicely longitudinally. You can see right near the insertion back here in the calcaneus. And so I don't always go back and look at these after I do them. This is one lady that was doing really well. And so obviously we wanted some of this data collection too, just for our own research and records as well. This patient was treated recently. He had a medial gastroc strain. So again, I kind of call it my pillar of treatment. We're going to go ahead and provide some immobilization with in this case, a tall boot, a PRP injection. We've been offered shockwave with him to kind of mechanically stimulate that. You could also think about it when the time is right on some of these injuries, physical therapy, focusing on ultrasound and some other things to help facilitate healing. But this particular patient was pain-free in 4 weeks. And so again, that's what we're looking for with these type of patients. And so what do I tell my patients in the office? And I think this is where it all begins. This is where the rubber meets the road, if you will, and this should be initiated at the first appointment with our patients. First of all, I cannot guarantee any improvement with these injections, although in certain situations, and I'm very picky on who I will offer these type of injections to. I think it'll really work in the right patient as long as they listen to you post procedure, your instructions, and they follow through. But it's an option I have before surgery for patients. And as we'll talk about in a minute, I even supplement a lot of my surgical procedures with biologics. Although this is relatively new, if you will, or newer compared to some of the other techniques we have, the science behind it, and again, the increase in data and the better studies we have really makes sense, and the early results have been promising. I tell patients damaged collagen can take 9 to 12 months to remodel, so this isn't something you're necessarily going to see a response right away. But in our series of patients, we've got over 200 now. With these, we keep track of a lot of our data points, but we're seeing less pain, and somewhere anywhere between 45% and 95% in 4 to 6 weeks. That's generally what we're seeing. Of course, we've had some patients who've gotten very little relief, and Some have been all the way up to 100, of course, but again, that's kind of our range. Detailed consent form beforehand, again, along with expectations. I would implore you. I think that's huge for doing this. So my kind of my rationale for this is we want to get somebody back up and moving as quick as we can, but as safe as we can. So offloading we talked about. We're going to add some biology with PRP. Can add some physical therapy or a shockwave type treatment. Time is the ultimate factor in how long this is going to take. But I also think nutrition plays a role in this too. And we try to treat people at that end. So I talk to them about, you know, different medical foods and even vitamins and supplements and things like that, but just trying to get their nutrition on par as well. So we get, again, the best possible outcome with this. I generally tell my patients I'd like them to stop with NSAIDs about 2 weeks before procedure. If they're on anticoagulants, we generally want to get an okay from their prescribing physician to have them come off those before. And then afterwards, I'd like to keep them off NSAIDs for 4 to 6 weeks. Immediately after post-procedure, I'll offer them a Tylenol or even just a low-dose Vicodin if need be. We try to get them. In therapy, not right away in the office. They need to be ready to go. That means whatever injury we're trying to treat needs to be calmed down, if you will, or else I think they're just going to exaggerate their symptoms, just make those worse. And I think with the old systems, I used to tell people you may need a second injection, and it could be anywhere from 3 to 4 months down the road. It just kind of depends on how you're doing. And I think with the increased concentration and numbers of platelets we're getting with APEX, I don't think we'll have to be able to say that, or hopefully we won't have to be able to say that too much longer. So we've treated, again, we're up over 200 now, everything from joints, tendons, and ligaments from the knee down. Got a pretty extensive data collection going right now. I've got an unpublished paper on 57 ankles 1 year where we just provided them with a PRP injection in the office versus an arthroscopic debridement with a PRP injection as well. And we actually found statistically significant improvement in both groups. And actually the groups I scoped out actually did even better overall. So I need to get that published. PT with ultrasounds important as well to help with healing, as well as, again, as we talked about, the offloading. And I know Dr. DeMers is going to go through a lot of this, but again, there's a whole business side to this too. I mean, this is literally my backyard in Sarasota, Florida. So I live in Siesta Key on a barrier island. So, you know, this is what we like to do on the weekends and things like this. And with this being said, this is a cash service that I offer in my office to supplement my insurance patients as well. I generally will get an office visit out of it when the patients come in, an ultrasound guided injection, and we will bill that part through their insurance and actually get paid on it. They're usually going to get some sort of a DME product from us. If you've got physical therapy in your office, that can also be utilized when the time is right. And again, anything from arthritis to tendon and ligament pathology. I've had excellent results with this in plantar plate, both repairs and tears in the office, as well as chronic and long-standing plantar fasciitis. So when we start transitioning out from maybe more of a traditional surgical practice into a regenerative type practice setting, which again, I'm a hybrid at this point, regenerative medicine is a different arena. The expectations are different. It's really different for a patient when they're paying for something out of their pocket, or their credit card or their checking account, versus their insurance. And if things are covered and not covered, and believe it or not, outcomes can make a difference with this. And so somebody's going to feel a little shaded if they're paying a couple grand out of their pocket for something, and they may not feel as bad if their insurance takes care of it and they don't get the results that they want with that treatment. So that's why we also allow our patients, they can use an HSA form, very detailed consent form. We have them all fill out the ABNs that they're not going to submit anything to Medicare. But again, it's all about those expectations that you initially lay down. I tell my patients this is not a steroid injection. It may hurt a little bit during the procedure. So what we try to do is keep our local away from any injections if we're going to localize somebody first. Close enough with your injection is not good enough. And that's why really, if you're going to do this, do it under ultrasound guidance, or have somebody come into your office who can provide that service for you so you can get that that injection in the correct location. Patience is essential, and that's one thing I reiterate into my patients over and over. early return to sport or play can be detrimental. And a good way to talk about it to a patient, hey, this is an investment into your healing, into your overall activity level down the road. And so when we start talking about them in that manner, a lot of patients are quite receptive to that as well. Again, we've kind of gone over this before. Just make sure we also, especially in the lower extremity, you need to immobilize, you need to offload whatever area we're treating. And I would do this in order to get the best possible outcome with my patients. And this is one thing they won't comply with before treatment. I'm a little apprehensive in at least providing it to them, because if we're going to do it, we want to do it the right way. I tell my patients I don't want to cut corners. And so we really like them to participate in this. And it also does help them participate in their healing as well. And so, and I know for the clinicians out there and physicians, I mean, we're all bombarded. This was an email I got. We're going on 5 years with this, but I still get these type of things all the time. And again, this is from a rep saying attached, and they sent me a bunch of clinical references of our PRP system. Over the years, PRP technologies have been used on a multitude of surgical and clinical applications as regenerative therapy options. Some of the studies published with PRP are in multiple journals. Most recently, there have been phase 2 and phase 3 studies published and presented at major conferences, highlighting how successful PRP is for regenerative use in chronic inflammatory conditions. So my typical response back is, do you have any data on your product? And the rep, well, we don't have specific clinical data with our product, but it seems to work well. And so this is some of the answers you're going to get from these reps who are coming in. So again, that's important for you to do your own homework on this too, and you need to have some background on this. And so to kind of switch gears a little bit, because I run a hybrid practice, if you will, I'm still seeing insured patients and doing surgery. I think this is a great adjunct too. I offer PRP in surgery to patients. I still get a lot of people that come in and ask for it, but I tell them it can help supplement the repair, augment the repair, and again, anything we're operating on in the foot, ankle, leg. Again, these are all applications where this could be utilized as well. This is a 39-year-old male. He was a self-pay patient, presented to me. It's insertional Achilles pain for over 10 years, tried a bunch of different conservative options. And so we talked surgical options with him, including an open GSR, gastroc release. We fixed up his Achilles and debrided down the posterior aspect of the calcaneus. I did an FHL10 transfer with the tension slide technique, PRP injection too to augment this. And this was all done, at the time of surgery. So after the incision's closed, I'll place some of this deep, and then just basically everything's closed. We'll go ahead and just pepper the tendon that we repaired with that as well for this. Arthroscopic procedures, I do a lot of all arthroscopic lateral ankle stabilization. So again, this is another application for this. What I like to do though is I've started doing my surgeries, and then what I'll do is I'll close the patient up, bandage them up, and I'll see them back in my office about 10 days later, 14 days later. I'll do the PRP injection then in the office, and I thought process with that. And again, I don't have data to support this, but with these scope joints, you've got a lot of fluid in there, and as soon as we put our dressings on, some of that fluid is obviously going to come out of the portal sites. Even though we suture them together, you're going to lose a little bit of that. So my thought process is, if we're waiting, to the first visit back, hopefully we can maintain more of that into the area that we want it to stay in. This was a Lisfranc, subtle Lisfranc fracture dislocation that we did. So we fixed this in the operating room. And then under fluoroscopic imaging, basically here with a dynamic fixation, injecting the PRP right in between Lisfranc's ligament, and so that's pretty easy to do. Another application, I've had great results with this, and we published a couple papers on this, but this is for a chronic plantar fasciitis treatment or an interstitial tear treatment. This is what we do with this now. So we make 2 small portals spaced out about 2 centimeters on the medial aspect of the ankle. The proximal portal is straight down from the posterior aspect of the distal tibia. And just like this, we're drawing right down. We'll go ahead and just 2 small portals, go ahead and stick my cannula, an obturator and cannula, trocar in, scope through the distal portal, shaver through the proximal portal, and this is my working portal. You can see in the bottom of the foot there, there's a spinal needle going in, and that helps with orientation. So what this procedure is, it's just a simple debridement of the plantar fascia. It's not a resection of it. I'm not cutting the plantar fascia like in a lot of these other procedures. I'm resecting all the scar tissue out, which you can see on the picture on the left here, that kind of maroon, darker colored tissue. That's scar tissue on top of the plantar fascia. You can see the inferior calcaneus. In the picture on the right here, my spinal needle is being introduced to the inferior aspect of the foot. My probe's on the plantar aponeurosis all the way back to the inferior aspect of the calcaneus. And so the first time we kind of saw this, it was pretty cool. You could actually see what we were doing and how much scar tissue's in there. I can get a shaver in there on the left there of that picture, right underneath the inferior aspect of the calcaneus. And if there's a spur underneath there, remove it if the patient desires. A lot of times that's just psychological with the patients. They like to see those removed post-operatively. And then I'll take an ablator and come in and just kind of thin this out to physiologic thickness. And I think it also prevents post-procedure bleeding and the formation of new scar tissue. So just really quick, I just want to show you what this thing looks like. This is what foot and ankle surgeons, sports, whoever, this is what we are all treating with our injections, our orthotics, our physical therapy. This is what it looks like when you first get in there. You can't see anything. So you've got to create a little working space to work in. That tissue right below, that real bright red tissue, it almost looks like muscle. Well, guess what? That's all on top, the superior aspect of the plantar aponeurosis. That's the scar tissue that forms in there. So I think that's really the nidus. That's the problem with this. It's that chronic scar tissue and inflammation. So thereby removing that and just debriding that out with the shaver, I call it vacuuming the carpet. It looks like red shag carpet from the 70s. We're able to get a nice glistening ligament back to where it's supposed to be. And if there's an interstitial tear, we've got some techniques we're working on to go ahead and repair that with some meniscal repair devices. So here you can see in this particular patient on the left, you can see my spinal needle poking up and through. You can see all that red inflamed scar tissue again there. And then the picture on the right is after that's been debrided out, and I'm continuing to debride that out. And that's what we're looking for. And that's when that's all said and done. This is a perfect application under direct arthroscopic visualization. Once the procedure is done, I will often go ahead and inject my PRP into this as well to augment healing. And again, we've seen excellent results with that. And just proving here that we don't cut the ligament's intact and it's in place. Heel spur on the left before, and on the right post-procedure. Again, all done through the scope. Same thing on this one before. And again, we all know the heel spur generally doesn't cause pain, but when a patient sees that, I think it makes them a little extra happy. And that's what we're always looking for. So my journey with this, with the PRP, Winston Churchill or Mr. Chow, Leslie Chow said this, I think now's not the end, not even the beginning of the end, but it's perhaps the end of the beginning. And especially with some of these newer systems, PRP systems we have out there, I think it's going to help really facilitate this and better studies out there. So I guess my summary would be, do your homework on PRP, on some of the different systems out there, understand the basics behind PRP and how it can help your patients, both intra-articularly and with soft tissues. Consider the offloading, consider other modalities as well to help your patient heal, whether it be physical therapy, shockwave, nutrition. Not everybody's a candidate for this. And so that's your job, that's our job to weed these patients out as far as who's gonna benefit and who's not gonna benefit. But again, be clear, very clear up front with your expectations is probably my best advice on anything in this little short talk. So that's what I got. I thank you for your time. Appreciate it.
Thank you so much, Dr. Cottom. We really appreciate your time and sharing your insight. Dr. DeMers and Dr. Cottom, if you have a moment, I was going to try and sneak in three or four clinical questions. We're getting kind of a mix of clinical and cash pay. So I'll save some of the cash pay for after you go, Dr. DeMers, but there was a couple of questions that came through, all kind of asking a similar type of question, but basically, do they want to know if you guys use any anesthetic or if you utilize any of the canes when you inject PRP, and does that get mixed with the PRP at all? and how do you address that?
Yeah, I'm happy to address that. Hopefully you can hear me and see me now from Turkey. I found the power. That's great. And so there's been some really good data regarding anesthetics. I think that it's clear that bupivacaine is chondrotoxic and cytotoxic and not to be used in these orthobiologic applications. Low dose or dilute lidocaine or ropivacaine has been shown to not be detrimental. And so I think for the comfort of the patient, as well as, getting them out of your office comfortably so they can go home and then be uncomfortable. I do use a dilute either ropivacaine or lidocaine. Especially with my soft tissue procedures. I think the intra-articular only procedures don't really have that same discomfort when you're doing these in the office.
Okay, perfect. And kind of to follow up with that, they asked what each of you do to counsel your patients regarding expected or typical onset of benefit. In my experience, it can be up to several months.
Yeah, I generally tell my patients, I hope you have some pain relief in 4 to 6 weeks. I'm not going to give them a percentage on that, but ultimately I can tell them 6 to 9 months for soft tissues, and it takes a while. It's that whole, the expectations are it's going to take time and everybody's different. So I kind of leave it a little bit vague and just say we're going to monitor you very closely. I think that's important.
Okay.
Absolutely. I see everybody back at 8 weeks, and that is my first follow-up. And that expectation is to make sure they're on trajectory for a 6-month trajectory with approximately 40 to 50% improvement only. So it's a long haul, and I think counseling the patients are really, really important. So, because they come in and they forget that I tell them this, and they're like, gosh, I thought it wasn't working. And I'm like, no, this is this is why we have this meeting, to make sure you're on trajectory, make sure we don't need to redose you, make sure we don't need to add or take anything away. But this is the first time, this is the earliest time that I want to see you back. And they're like, oh, I thought I was a failure. I'm only 75% better. It's like, well, you're above trajectory and we're doing fine. Just relax. You have 4 more months of improvement to go. They're like, oh my gosh, this is amazing. This is the best. But it takes a long time. So they do need that hand holding. They do need that reassurance.
Thank you. The last question is, there's several variations of this, but essentially, when you're utilizing the protein concentrate, do you use that in combination with PRP or alone? And what indications do you generally look for to utilize the protein concentrate?
Yeah, currently I'm using it intra-articular for to make sure that we have those proteases kind of neutralized. I do think I prefer to have a more inflammatory effect with the soft tissue applications, but anything that maybe needs a bit of scaffold or something to that effect, it is quite viscous, and so you can also use that. Dr. Cottom, what are what's your favorite that you're using it for right now?
The concentrate?
Yeah.
Intra-articular injections. Just I like it for ankles, other joints as well. So that's my go-to for that. So
Awesome.
Yeah, I would agree. I would agree.
Great. Well, thank you. Well, due to time, we're gonna move on kind of to the cash pay discussion with you, Dr. DeMers, and Dr. Cottom. Again, thank you so much. I really appreciate your insight, and all of us do here. That was great presentation. Thank you.
thank you.
Yeah, Dr. DeMers, I'm gonna go ahead and get
Great
your
stuff.
slides
Awesome.
here.
Thank you.
Should be able to see those now.
All right. So I am sort of obsessed with this whole business aspect of the orthobiologics. And really, this is empowering for your patients. So we want to embrace those cash pay services. And part of it is to empower your patients to make better decisions. And if you will go to the next slide, I think maybe I can do it, or maybe I can't. But I'll let you're in charge. So
Perfect.
why do we do cash services? This empowers the patient, right? They get autonomy. They get to choose how they spend their money. They have transparency. They know what they're buying. There's nothing that's opaque or maybe not included or not talked about. And then you get to choose when you're using your cash, you have access. And then you can, with most of these cash pay services for platelet-rich plasma or cellular therapy, this is personalized care. And I think what Dr. Cottom was bringing to the table is you can dial in with the benchtop press. You can dial in your type of injectate. You can go leukocyte depleted, leukocyte rich, or monocyte rich, or any concentration, or even how much from a volume perspective you want to use for this benchtop press. And then they get to be an active participant in this journey and make those decisions. So how do we empower our patients? We have to educate and inform, build trust and transparency, and then address these concerns and provide support throughout this cash pay journey. So educating and informing our patients, we always have to talk about the advantages of cash pay. Number one, you know what you're buying. Number two, we have to go ahead and provide those specific benefits for the procedure. And then really, really, really key is you have to demonstrate value. What I tell my patients, but also what I tell my colleagues is if they are saying no, it just means that you haven't demonstrated enough value to the patient. We all know these treatments are super valuable. Otherwise, we wouldn't be here tonight. We wouldn't be talking about this. I wouldn't be obsessed with it because I know I can get great outcomes for my patients with orthobiologics. And so really, we want to start with this pre-framing. We want to create these welcome videos before practice entry so that they are already seeing you, already knowing you, already interested in what you have to say. You can give them education on orthobiologics so you become this trusted source, this person who knows what they're talking about. And then when they come, we want to identify why they're here. We want to identify their goals, their pain points. So honestly, when I have my MA room these patients, they're already delving into, well, why are you here? What brought you here today? How can we help you? Man, what's really bothering you? The diving down into the actual why they're there. So then we can start to pre-frame and start to pre-construct this visit to give them a win. So I always ask them, what would be a win? What is something that would be a benefit? What if they're coming to you for plantar fasciitis and they've really been struggling for the last 3 years, maybe the win is that they can walk on a daily basis without pain. But what I would recommend is not that you put words in their mouth, but honestly, you ask them, what would you consider a home run? Where would you say, oh my gosh, if I could achieve this, I would be so excited. I would be over the moon. And so if we can then have them define what that win is, then we're going to go ahead and tie back what they're purchasing, what they're spending their hard-earned money on to achieve that goal. So we need to build trust and transparency. We don't want to be that used car salesman. And you highlight this expertise that I'm a national expert, that this is a very safe procedure. It's much safer for the majority of what we do as surgeons. Injection-based therapy has a very, very high safety profile considering. And then you need to be clear and concise on cost. Don't beat around the bush. Just tell them what it is. Encourage questions, encourage second opinions, go, provide them the education, and then provide them multiple ways to access. So you can provide them a handwritten document, you can provide them a link on your website, YouTube videos, going ahead to make sure that they know, like, and trust you. When they know you and they like you and they trust you, they are inclined to do business with you. So about the money, everyone stresses out about the money, and we're so ingrained. Oh, you don't talk about money. You don't talk about money. Oh, you're the doctor. Don't talk about money. But honestly, this is really important to just spit it out. Don't beat around the bush and be like, well, it's sort of kind of maybe expensive-ish, and maybe just tell them the price. Just like when you go to the store and the bread's $4. It's just $4. There's some fancy, whole grain, expensive and organic, $6.50 bread, and then there's the Wonder Bread. The Wonder Bread is 2 slices. You put the stuff on it, it'll get the job done, but maybe it's not that fancy. Maybe it's not the best choice. But if you've got $2, it's a great choice. But really just talk about the options and the price, and make no judgments about what they may or may not be able to pay for, or maybe they will, but they need to have those options available so they can make those decisions. And like I tell my patients and I tell my office staff, we are not salespeople. We are in the education and guidance department. Our job is to educate fully on all of the options, and then guide them to what's the right option for their specific personalized problem. So when we talk about cost and concerns, we have to address it. We have to address that elephant in the room. A lot of my patients are like, well, how much is this going to cost? I'm like, I tell them the price. They're like, oh, I thought it was like $10,000. And so this perspective, or this perception that it's out of reach, may or may not be true, but without talking to them very clearly and plainly, just talking about the price, they won't know. And if you don't offer this to them, then they can't say no. They don't even, you've taken away the opportunity to say, oh, that's not for me. Oh, that doesn't fit my budget, because you didn't even offer this to the patient. So talk to them about the insurance or coverage, or not coverage. There's a number of insurance companies and a lot of the Medi-Share plans that will cover these. Work comp, for the most part, covers this. And then you talk about payment options, financing plans, but always tie it back to their goals and guide their decision based on their goals and what treatment best achieves their goals. So I always tell people, don't focus on the bridge, focus on what's on the other side. You're not selling the bridge, you're selling the goal, the end result. So this is the San Francisco Bridge. This is by my house, and it's as physicians, we always get kind of excited about this widget or this treatment. They're like, well, it's great, it's got platelets and it's got 10 billion, and we're going to inject it under ultrasound guidance, and it's going to be this, that, and the other. But really, if you were going to San Francisco, you don't care how many guy wires and how many bolts and how many light posts are on the bridge to San Francisco, because you want to get to the other side, right? You're using the bridge as a means to an end. So don't sell the bridge, sell what's on the other side. You use the pre-framing, the know, like, and trust, goal-oriented consult. By all means, get the right diagnosis. I think sometimes in our current medical climate, we don't have enough time to do a great job and get the right diagnosis, because honestly, we only have 7 minutes, and to 7 minutes to get to know the patient, do the physical exam, get the history, and come up with the perfect diagnosis, sometimes we miss the mark. So take the time, get the right diagnosis, give them all the treatment options, give them the price, and then just shut up. Don't talk about why that's the right price, or well, maybe they could do something about the price. The price is the price. And then schedule the treatment that they need and deserve, whether that's surgery, whether that's physical therapy, whether that's injection-based therapies. That's how I go about educating and guiding my patient. Working in Turkey, I just got a message that it's unstable, but hopefully we were still on par. So what we'll talk about for a little bit is, I always hear this is, but you don't understand. You live in California, my patients are different. So I wanted to just give us a little perspective on what I tell my patients. And so we can go through some of these objections for cash pay procedures. The first one is going to be, well, but I have insurance. Make sure that you are on the side of the patient and not the insurance company. And so I'm always happy to throw the insurance companies under the bus, and I tell them, well, unfortunately, your insurance company has decided that they don't value this procedure, and so they're choosing not to pay for it. But then you can highlight those benefits of cash pay services: quicker access to treatment, personalized care, flexibility in choosing who they go see, when they go see them, and why they go see them. The next one, excuse me, the next question is like, well, how do I know it'll work? And so this is a really good opportunity for you to showcase your expertise, your knowledge, and your experience. Provide them with successful outcomes, experiences, the patient satisfaction ratings, your testimonials, and give them the statistics on your data collection and the data collection that's out there. That the numbers don't lie. So then the next one would be, but I'm afraid of the procedure. Is that a big needle, or what's it going to be like? And so take that opportunity to really make sure that they trust what you're doing, this is how we ensure that you're going to be as comfortable as possible. Sometimes it's not possible to be completely pain-free, but we use nerve blocks and numbing medicine. We use these techniques or that to make sure that they know what to expect and when, including what to expect before, during, and after the procedure. So yeah, I always get this, well, I'm not sure if it's worth the cost, right? And so those case studies, that data showing that it's an effective procedure, that it's a cost-effective procedure, make sure that you compare this to a surgical cost. What I think we forget these days is that insurance doesn't cover as much as you think it does, and people's deductibles are $5,000. $7,000, $10,000 to get their medical care. That's upfront before they get the insurance kicked in. That's their deductible. And so if you can come in and save them money, as well as time, as well as discomfort, as well as risk, that may be worth the cost of the money that they're going to be putting up front. And then the last one is, well, I can't afford it. And sometimes that is true. Sometimes that just, they're on a fixed income and they cannot afford these treatments. There are some practices that I work with that have a indigent fund. They have a scholarship fund that they are allowing their patients who truly can't afford it. The lucky thing about cash pay procedures and cash pay surgery or cash pay treatments is you can choose to not charge the patient. It's outside of insurance. This is a between you and the patient thing that you can decide. Today, it's Tuesday. It's the second Tuesday of the month, and then there's no charge for any of the procedures I'm doing today. That is a possibility when you are doing cash pay. But then also, I also do flexible spending, health savings, as well as I take care credit, which most people are familiar with for their pets or their dentist, and that also works. So just make sure that we're doing that. So please don't sell the bridge. People want the destination. This is what we're doing. This is what we're talking about. And I think hopefully I've equipped you with some reasons to help educate and guide your patients. So please empower your patients through autonomy, transparency, accessibility, and personalized care. if you are interested, please don't forget, there is a podcast that I have. This is my podcast on the business of orthobiologics. This is super beneficial if you're looking to integrate cash pay services. It kind of walks you through what to do and how to do it. Anywhere you find your podcasts, please, please, please come visit me, come subscribe. And I thank you so much for your attention. I hope that this was helpful, and we'll take some time to go ahead and answer some questions as well. I see there's a lot of questions on the web chat.
Yeah, Dr. DeMers.
Let's see. Should we just run through these, or do you want me to go ahead and?
Yeah, if you want to address a few of them, then I've had a few more direct messages come through.
How do you want me to do this?
Oh, shoot. Can you hear us okay, Dr. DeMers?
Oh, I totally can. Is this
Okay.
good?
Yep, perfect. Now we can hear you very well now. Okay. Yeah, so there's a couple of questions that have come through as far as having that conversation. I feel like this one was answered, but maybe we'll just recap it as well. It says, do you talk about price directly with patients or have an assistant discuss pricing?
No, they know, like, and trust you. I have that discussion. You can have the assistant, but sometimes it feels like it's the pass off, or it's like somehow like, oh, now you're gonna go to the hard sell. Whereas it's just the price. I'm not trying to sell them anything. I'm just telling them what it costs.
Okay, perfect. And then there was also, in your experience, what has been the most effective way to market biologics?
Word of mouth. Word of mouth, hands down. I actually spend zero on my marketing budget. I don't market at all. It's all word of mouth. The happiest patients will tell people, 100 people, that they had this treatment. You have to go see them. People show up in my office and say, "I'm here for the thing." I'm like, "Well, what thing?" He's like, my neighbor had this thing. They had the injection. They're perfect. I want that. It's like, okay, well, let's make sure you're a candidate, but perfect. That's going to work out great. Let's see if we can't help you out.
And then we actually had another one come through. They wanted to get the name of your podcast.
Yeah, it's the business of orthobiologics.
Perfect.
Just on anywhere you get your podcast feeds. I think that's been my labor of love, and I've been trying to get the word out about this is hard. This is not something that we learned, and it's a scary leap to offer cash pay services. And we've done it to varying degrees, but I think that there's really been I think that that's a big hurdle for adopting this amazing technology.
Yeah, we'll make sure to include the title of your podcast on the webinar recap, just so everyone has quick access to that as well, just for those of you. We probably have time for maybe one or two more questions. One that came through was, how do you handle explaining failure, for example, on a bilateral injection, if they had success on the left and failure on the right? Do you do any type of refund, re-injection, or how does that work?
Yeah, so sometimes, as we all know, left and right are not equal, right? And so it may be that there was a more severe disease or it was more recalcitrant. And so I do take that time at that 8-week time frame to decide, do we add something? Do we add laser? Do we add shockwave? Do we redose them and do another injection? Are they overdoing something? Are they a little bit more non-compliant with their post-injection protocols? Like what's going on? Are they trying to hike Kilimanjaro tomorrow and and they're thinking this is going to be the magic bullet? So I use that 8-week time frame to really decide what's going on. And I rarely refund. It's usually a dosing problem. If we're not doing well. There was a beautiful study. It's on knee arthritis, but it really highlights that there was 2/3 or 30% of patients were considered non-responders. And when you take those non-responders and redose them, 2/3 of those get better. And then there's this very small subset of non-responders. And so I do think it's more and more a dosing issue, rather than a out and out failure. Because I mean, if you're thinking that orthobiologics doesn't work, then we have a healing failure, and it's a person failure, right? It's a biology failure from the person, not we just haven't gotten their personalized treatment quite honed in yet.
Perfect. Thank you. And then one last one before we conclude for the night. Do you either of you offer a bundled let's see, do either of you offer a bundled option for PRP with protein concentrate? It looks like essentially they're asking, do you offer any type of bundled packages with pre-treatment, post-treatment, with shockwave included as well? Dr. Cottom kind of ties back into you mentioning including that with treatment. Do you do bundle options for those?
Yeah, I do. If we're going to offer two cash services at the same time, I just basically will, I tell the patient, yeah, we're going to bundle them together for you. So we'll give you a discount on that when we do it in that situation.
Dr. DeMers, similar.
Yeah, I actually do it different. Yeah, no, I do it totally different. You can't get it a la carte from me, because I want to give the patient the best option and opportunity for improvement. And so I go ahead and give them pre-treatment for nutrition and laser therapy, and then injections of either PRP or BMAC or what have you, and our post injection protocols, our post-injection pain relieving, topicals and bracing. So that's all included. And I don't want to shortchange them. And so it is a package deal.
Okay, so the price is the price when you lay it
Price is the
out.
price.
Gotcha.
It's like a gym membership, right? You don't use all the gym, it's still the membership price. It's your choice. It's all there for you.
No, thank you so much, Dr. Cottom and Dr. DeMers. And we also want to nod to Dr. Mandelbaum and for his participation tonight and everything that you guys have brought, and for all the attendees and the questions that they have posed. This has been very educational and very beneficial for all those involved. So again, we want to extend our gratitude and thanks to each of you. One last thing, if Dr. Cottom and Dr. DeMers, if you don't have anything to add, we would just like to extend an invite out to everyone who's interested in participating in data collection or any type of studies with APEX Biologix to please reach out to me. My email's here at jdurant@apexbiologix.com. We will also include that on the follow-up email as well, post-webinar with the recording, just so if there's anyone out there that's willing or interested in gathering more data, we would love to be in touch with you. So thanks everyone for participating. And again, thanks Dr. DeMers and Dr. Cottom. We really appreciate it.
Thank you so much. I really appreciate it. We'll see you guys later.
Take care, guys. Thank you.
Thanks. Have a good night.